Yes. Well, I'll make some closing remarks, which is mostly just thanking everybody who made this possible. But before I get to that, I guess I just want to make some observations and make a few comments, maybe 3 comments. And the first comment, I do think, Ewout kind of touched on this, but I do want to pretty strongly disagree with both Ralph and Frank that HTE is only when you find modification on the relative scale. You know, HTE fundamentally is, maybe you didn't say that. I was quote?
I said that because otherwise HTE always exists for every treatment.
Exactly. Exactly. So the way I would put it is that HTE is a scale-dependent concept, and you just have to specify the scale. And the issue is that clinically, for clinical decision-making, the most important scale is the absolute scale. And the problem is this idea that the relative scale, so somehow we think that unless you find a p-value that's less than 0.05 on the relative scale, you don't have HTE, is a very pernicious comment. And in fact, sometimes when you find it, it can be quite misleading because the high benefit group on the relative risk scale, you don't know if they're really the higher benefit group. They could be the lower benefit group because this distinction between predictive markers and prognostic markers is a little artificial because a lot of predictive markers also have prognostic value, and prognostic markers are predictive on the absolute scale. So that's a distinction that exists in our models, but and it's so informs our thinking that I think we're a little brainwashed by that distinction. We should always look at the effects on the absolute risk scale. Now, it could be true that this idea that a consistent relative effect is often a reasonable approximation of God's model, right? And that might be true, and maybe it's a good heuristic to use if you estimate just prognostic risk and you just assume consistency of relative effect. But you need to check it, because I showed maybe 6 examples, and half of them, when you looked across risk as a variable, the relative effect was not consistent across risk. And I think you'll sometimes find that across risk where you won't find it on the one variable at a time analyses. And again, the main reason to look at that is because modeling risk is just so much easier than modeling relative effect modification, for all the reasons I'm sure you're aware of. So anyway, that was a bit of a rant, I guess, at the end. But I just want to make 2 other observations, I guess. One is I just want to remember Harry pointed out in the beginning very generously that I taught him how to spell HTE. I don't know if that's true, but when I thought about the goals of this conference at the very beginning, I was thinking that a long-term goal of this whole agenda is if we could teach Microsoft how to spell HTE. Yes. Because it autocorrects to the all the time, and it takes me. So that's the long-term goal of this conference. The other, I do also want to recall my favorite moment of this conference. I do want to take a moment to, just recall my favorite moment of the conference. It was hearing Derek Angus kind of repeat with this really beautiful Glaswegian accent, some of the things that many of us in the room have been saying, and it just sounded so much more convincing. And then it was great when, John Spurtis stood up and, kind of banged his fist on the table and said, we should mandate that this happens in every RCT. So, that brought a tear to my eye because we've kind of been saying that a little bit for a little while. And, I don't think, the truth is I'm not the kind of person that wants to strongly mandate any of these practices, but I think, it was pretty gratifying just to hear that the idea seems to be getting some traction. And I'll even notice, people, Steve might have sounded a little a few notes of caution. But I have to say that 8 years ago, I think we submitted something to the Annals, which ultimately was published in the journal's Trials. And Steve wrote this very long review back. And so what I've heard from him now, I could tell you, he's evolved. He's evolved quite a bit, even though he sounded a little pessimistic. So that was really nice to hear. And the truth is, all the cautions I heard from Steve are totally valid cautions. So I thought I'd reflect on that. So I just wanted to thank everybody. I thought this was a great conference. I tell you, I had to hold myself back a little from speaking because I really did want to hear everybody. And my only regret is that we had a little bit more time for discussion because I think a lot of people didn't really have the opportunity to speak. So we hope somehow there's a time to continue this conversation. I'll say, please, fill out your evaluations. And I hope, as Joe was saying, that, this is the first of several conferences. So you don't see the banner anymore, but this was really a collaboration of 3 organizations, the National Academies, PCORI, and our group at Tufts, and then the planning committee too, who I'd really like to thank also. But from PCORI, I think Joe is right. We really owe a debt of gratitude to Evelyn, who really shepherded this conference and a lot of other things, projects related to HTE. Since she took over as Chief Scientific Officer. And it's been great to work with her. She's really been fabulous to work with. And Joe, too, has been a champion of these concepts. Jennifer Crosswell, too, has been quite a bit of help. The National Academies, we worked with, I want to thank Michael McGinnis. I want to thank Anne Marie, who was here this morning. And I especially want to thank Danielle Witcher for really working with us to put this all together and to take a lot of the burden off of us. It was really something. And so, and then for me, the team at Tufts, my deepest gratitude really goes to Jennifer Lutz and Dr. Jess Paulus, who really worked to put the meeting together from our end. I would say that, I couldn't do it without you, but that would be really overstating my role. So, I would say they couldn't do it without me, but they probably could. So, in any event, I just wanted to close with one picture because I can't resist. This is a picture that I show almost at the end of every damn talk that I give. So, this is a picture of a patient. And it's a patient that we'll never see because it's a person that doesn't exist, yet it's the evidence, the evidence that we get really is targeted to this patient because it's the morphed average of the real patients in the periphery. And it's, as a lot of the methodologists spoke about, especially in the second panel, it's a very difficult job to get evidence for the patients in the periphery instead of for the one in the center, but that really is our job. And so, just because it's hard doesn't mean we shouldn't try. So, and with that, I'd just like to thank everybody for coming.